welcome to Nursing 301. Welcome to the third term. Just think about it, guys. You're halfway there. Halfway there. Nursing 301 is on the fundamentals of nursing. Most of this course revolves around care of the infants, toddlers, preschoolers, adolescents. We talk about the family. We also do talk about male and female reproductive disorders. So it will be a fun term. Get ready, take a deep breath, and we'll get through this term. And it will go very quickly. So, pay attention to these lectures that I provide on YouTube because there may be some hints that here and there regarding information that you want to know on a test. So just be prepared. Just remember all homework is due on Sunday nights by 11:59 p.m. I will open the homework for review on Monday mornings. I will close it on Tuesday morning and open the next week's homework. Just remember, even though I have provided an area on my IoT, the e-supplements under homework are versions that you can print off, but all homework must be submitted through my IoT. So let's get started. We're going to start with Chapter 90, Male Reproductive Disorders. And of course, the male reproduction system is closely linked to the urinary system, and for that reason, urologists are often the ones that treat male reproductive disorders. So, diagnostic treatment tests that we have. There are the testosterone levels, which is checked in cases of erectile dysfunction or impotence or sexual dysfunction. Testosterone is partly responsible for sperm production and libido. The next diagnostic test that we can do is a prostate-specific antigen, or a PSA. A PSA is a blood test that detects a glycoprotein found only in the tissue of the prostate. It is elevated in prostatitis, benign prostatic hyperplasia, or BPH, malignant and metastatic prostate cancer. Factors that can affect the PSA levels are age, African ethnic origin, prostate infection, and individuals' relative normal levels. The prostate-specific antigen is best used in combination with a digital rectal exam for early detection of prostate cancer. And to avoid a falsely elevated PSA, you want to collect the blood sample before a digital rectal exam or 48 hours after. They can also do a nocturnal penile tumescence or an NPT test, which helps to determine if a client has nighttime erections. Some NPT tests can show the degree and duration of erection and provide definitive clues to the cause. The next is the duplex Doppler ultrasonography, which relies on imaging the cavernous arteries at the base of the penis before and after injection of a vasodilator into the corpora cavernosa of the penis. It may detect arterial problems of the penis or venous problems by ruling out arterial problems. So the duplex Doppler ultrasonography may detect arterial problems of the penis or venous problems by ruling out arterial problems. Remember, it may detect arterial problems of the penis or venous problems by ruling out arterial problems. Then they have the prostate gland biopsy. That is a needle excision of a prostate tissue specimen for histologic exam and to diagnose prostate cancer. There are 3 different approaches. They can do a transrectal biopsy, a transurethral resection of the prostate, and they can also do a perineal. So common medical treatments, they can do bladder irrigation. That is performed to maintain the patency of the urethra after prostate surgery and to help reduce any post-operative bleeding as the urethra passes through the prostate. And they also may do radiation therapy, and that may be used following the removal of a cancerous prostate to destroy any remaining malignant cells. So, data gathering, male reproductive system. We want to know about their urinary and reproductive history. We want to know their general health history. Do they have a history of any sexually transmitted diseases or exposures? Do they have erectile dysfunction, urinary dysfunction, inspection of external reproductive structures, and also a prostate exam and testicular exam? So if you have a client that is going to be undergoing any surgical procedures, you want to provide pre and post-op care and teaching for these clients, and you want to address any emotional aspects that may accompany reproductive disorders. So erectile dysfunction or impotence is the inability to achieve or maintain an erection sufficient to complete sexual intercourse. It can be classified as a primary ED, in which the client has never achieved sufficient erection, or secondary ED, in which the client has achieved erection and completed intercourse in the past. Contributing factors to erectile dysfunction are drug use, tobacco, alcohol, hormones, etc., etc. Antidepressants can play a big role. So remember, for the drug use, antidepressants. Chronic diseases such as renal failure, heart failure, atherosclerosis, and multiple sclerosis. Endocrine disorders. Number 1, diabetes. Can also be related to thyroid disorders, adrenal disorders, or pituitary disorders. Endocrine disorders. Number 1 is diabetes. Trauma can be spinal cord injury. Cardiovascular disorder. Number 1 is stroke. Heart disease disorders, inadequate vascularization. And surgery may be related to a prostatectomy, an ileostomy, or a colostomy. So remember, your contributing factors are your drug use, your antidepressants, your endocrine disorders, your diabetes, trauma, spinal cord injuries, and cardiovascular disorders, stroke. If the cause is unknown, men need an evaluation of hormone levels, nocturnal rigidity measurement, or duplex Doppler ultrasonography to determine cause and identify treatment options. Medical and surgical treatments. If the erectile dysfunction if it's truly psychogenic in nature, counseling in conjunction with treatment options is recommended. So oral medications, Viagra, Cialis, Levitra, they're vasodilators. And they're taken in pill form. They help the penis to fill with blood. You want to take with caution due to the systemic side effects. Life-threatening hypotension if they're using nitroglycerin. So remember, those oral medications are vasodilators. and they can cause life-threatening hypotension if used with nitroglycerin. Also, erectile dysfunction treatment, those medications can also cause priapism. So, vasodilating meds can also cause priapism, which we'll talk about that a little bit further on. Intraurethral suppositories. They have Elprostadil, which is Muse. It's smaller than a grain of rice. It's self-injected into the urethra. The pellets melt and they're absorbed into the corpora cavernosa. Tissues vasodilate and pull blood into the area, causing an erection. And it's more localized arterial dilating effect than Viagra or Cialis. Vasoactive intracorporeal pharmacotherapy, Aprostadil or Caverjet. You self-inject a vasodilating medication into the penis. There are also mechanical devices, vacuum erection devices, or vacuum constriction devices. They're non-invasive. They create an erection by mechanically pulling blood into the penis. Penile implants. There's different types of devices implanted in the penis to help achieve and maintain an erection. They may be malleable, which are pliable, soft, and workable, or a 2 to 3 piece inflatable prosthetic. With the malleable penis, it looks erect at all times. And, the inflatable prosthetic can be inflated and deflated, stimulating a natural erection. Each of them have their advantages and disadvantages, but they want to avoid sexual activity until they are cleared by their physician to do so. And penile revascularization. It is rarely performed. Remember, penile revascularization is rarely performed. Only about 5% of all men with erectile dysfunction are candidates. It involves the reconstruction of the arterial blood supply or removal of veins that drain blood from the penis too rapidly. So, your oral medications, they're vasodilators. They can cause life-threatening hypotension if it's used with nitroglycerin. And the penile revascularization is rarely performed because only about 5% of all men with erectile dysfunction are candidates. And then just real quick about the priapism. That is a side effect of the vasodilating meds. And priapism is a prolonged, uncomfortable erection lasting 2 to 3 hours or longer. They need to seek medical attention for erections that last longer than 3 to 4 hours. So, like I said, priapism is abnormal and persistent penile erection without sexual stimulation. It is extremely painful and can last several hours or even days. They have to seek immediate medical attention. Many known causes: it could be penile or spinal cord injury, a tumor, cerebral spinal syphilis. Pelvic vascular thrombosis is most often identified as the cause. So, and then we have premature ejaculation. It is a consistent problem where ejaculation takes place before, during, or immediately after penetration. Treatment is wearing a condom or performing a special squeeze technique, applying lidocaine gel and meds, and the meds are serotonin receptor inhibitors. And Peyronie disease is an accumulation of plaques or scar tissue among the corpora cavernosa, causing a painful curvature of the penis when erect. It is idiopathic and benign. How they treat it is with oral meds, vitamin E, NSAIDs, and the what we want to educate the patient on regarding Peyronie disease is the plaque or scar tissue may be removed by surgery. And you want to make sure that you document your education that you provided the client. So, Peyronie disease, the one thing I want you to remember is the plaque or scar tissue may be removed by surgery. Undescended testicle or cryptorchidism. It can be unilateral, it may be bilateral. It should be corrected early in life to allow for successful sperm production, as internal body temp is too warm for sperm development. And undescended, what it means is the testes have lodged in the inguinal canal, and sometimes they will they'll secrete adequate hormones, but will most likely will not produce spermatoza. And if they may provide hormone therapy, and if hormone therapy is unsuccessful, they will perform an orchopexy, which is suturing the testes to the scrotal sac, and they usually do that between the ages of 5 and 7. But what we have to remember is that both testes remain in the abdomen past puberty. They will either be malformed or atrophy. Abnormal urethral placement. Hypospadias is where the urethral medius is located on the underside of the penis. Epispadias, the urethral meatus is located on the upper surface. So remember, hypospadias, located on the underside, hypo, under. If congenital, it'll usually require surgery if it is severe. Phimosis, that occurs in men who have not been circumcised, where this foreskin becomes so tight it will not retract over the glans penis. Can also be caused by injury. Circumcision can relieve the condition, and it can be related to catheter use. Torsion of the spermatic cord is the twisting of the spermatic cord, which results in the interruption in blood flow to the testicle. It's uncommon. It occurs most often in adolescents and young men. It may be caused by bilateral and congenital absence of the lateral attachments of the testes and epididymis to the scrotum. Causes of it can be extreme cold, like the polar bear plunge. Torsion of the spermatic cord. Causes can be extreme cold, like the polar bear plunge. It can be spontaneous, and it may occur in their sleep. Signs and symptoms are sudden severe scrotal pain, vomiting, abdominal pain, and nausea. It can cause testicular infarction and necrosis, and surgery is an emergency. So they need emergent surgery. A varicocele, that is an abnormal dilation of the testicular veins in the scrotum. It acts for 30 to 40% of male factor infertility, results in low sperm count as the scrotal temps are higher, related to blood pooling in the area. Signs and symptoms of a varicocele are swelling and nagging dull pain in the scrotum, more commonly seen on the left side, as the left spermatic vein is longer than the right. If it's on the right, it may suggest an obstruction of the intra-abdominal venous drainage related to a tumor. And then we have with the varicocele, treatment is surgery, and they've seen an improved semen count in 60% of infertile men. So a hydrocele is an accumulation of fluid in the space between membrane covering the testicle and testicle itself caused by infection or injury. Treatment is by aspirating fluid, surgical removal. And sometimes they'll do a plication, which is a stitching of folds or tucks in the hydrocele wall to reduce its size, usually to prevent reoccurrence. Symptomatic treatment is ice packs, scrotal support, emotional reassurance that the condition will resolve and will not affect fertility. Just cover this really quick. The digital rectal exam, DRE, provides basic knowledge about the size of the prostate. Labs that they would do are CBC, UA, creatinine and BUN, PSA, and remember, you want to draw the PSA before the digital exam or wait for 48 hours after. And then also with BPH, you will see changes in their UA, their urine culture, serum creatinine, and BUN. They may want to do a poise void residual test or a urinary flow test or urodynamic and pressure flow study. Those are just different tests that they can do to test for BPH. But remember, with BPH, it is one of the signs is difficulty voiding or emptying the bladder completely. Cancer of the prostate. It's almost always adenocarcinoma. It's a gland cell cancer, fairly common in men. Risk factors are incidences in increase in age after age 40, African American heritage, they're 60% more likely. Obesity, they're more likely to have advanced cancer. Diet high in animal fats. Family history of prostate cancer. Chances increase if an immediate blood relative has prostate cancer. High testosterone levels. Prostatic intraepithelial neoplasia, where the cells look abnormal under the microscope, and usually there's no symptoms until age 50. And then genome changes, that's the presence of the BRCA1 and the BRCA2. Cancer of the prostate commonly metastasizes to bones, lymph nodes, brain, and lungs. And remember that cancer of the prostate, signs and symptoms, it usually does not produce symptoms. The first sign it involves is difficulty in voiding. So remember, cancer of the prostate does not usually produce symptoms. The first sign involves difficulty in voiding. Neoplasms and treatment, prostate surgery. So preoperative nursing considerations, we want to provide education regarding strong possibility of postoperative erectile dysfunction, and we want to talk to them about a sperm bank, especially if they're younger. You want to give plenty of fluids, antibiotics prophylactically. They may have it may be possible that they could have a suprapubic cystoscopy catheter, continuous bladder irrigation for at least 2 to 3 days after surgery. Do not DC that bladder irrigation unless you have an order from the physician. You cannot even flush that bladder irrigation unless you have an order from the physician. Then we have our transurethral resection of the prostate. That is most common. And the complications of that is hemorrhage, urinary retention, and stress incontinence and erectile dysfunction. Prostatectomy. They can do suprapubic if the gland is 100 grams or more. They can do perineal, which removes gland tissue through a perineal incision, which makes sitting up very difficult. So remember, if they do a perineal approach, it makes sitting up very difficult. They can also do a nerve-sparing radical, where that removes the prostate through an incision below the umbilicus and above the symphysis pubis. That causes less erectile dysfunction and bleeding. So the nerve-sparing radical is they remove the prostate through an incision below the umbilicus and above the symphysis pubis. They can also do cryosurgery, which is an incision in the perineum, and they have a special tool utilized to freeze the tissue. Risks are similar to other types of procedures. And then post-operatively, if their catheter becomes clogged, like if they have the TURP done and they have bladder irrigation going and a catheter becomes clogged, they can have overdistension of the bladder, which can cause them extreme discomfort. But post-op, we want to provide them with TED hose. We want them to get up and move around. We want them to use their incentive spirometer. We want to encourage fluids and stool softeners. Some gentlemen, like I say, will have the triple lumen catheter, which is one lumen inflates the balloon, the second drains the bladder, and the third irrigates the bladder. So, that's, we want to monitor their I's and O's. So just remember, if they do bring in, or they decide to do, if they have a continuous bladder irrigation going, you need to monitor that system and that setup to make sure all tubes are open. You want to make sure all catheters remain taped in place. And if you have to irrigate it, remember, you need a physician's order. Must be irrigated. You need a physician's order to irrigate the bladder manually. Medical treatments for cancer of the prostate depends on the disease stages and the client's age and their symptoms. They can do radiation therapy, where that reduces the tumor size, or actually to cure some stages of cancer. They have the radioactive seed implantation. That is a common method. It's a small radioactive seeds that are implanted directly into the prostate, and it reduces side effects. They can get radiation cystitis, which is a common problem following radiation therapy. Treatment is analgesics, antispasmodics. You want to increase their fluid intake, and they are susceptible to excoriation and yeast infections. Prostatitis is an inflammation of the rectum and anus. You want to use low residue diet and antidiarrheal medications. They may experience with urethral stricture, but you want to educate them regarding signs of urinary elimination to monitor their I's and O's. and to decrease or stop testosterone production. And then we have hormone ablation therapy. That is, prostate cancer needs testosterone to grow. An orchiotomy will solve the problem or remove a portion of the testicle that produces testosterone or meds to decrease or stop the testosterone production. I did say that with the previous about prostatitis. That does not go with prostatitis. It goes with the hormone ablation therapy. I'm sorry about that. We want to make sure we um, provide pain management in advanced diseases, especially if it's metastasized. And prostate cancer screening may not be desirable or effective for all men. Also, a client can develop cystitis or proctitis as a result of chemoradiation. So, you want to, if they have developed cystitis or proctitis, you want to carefully monitor that client's urine output. So, if they have developed cystitis or proctitis as a result of chemo and radiation, you want to carefully monitor the client's urine output. Sorry about that. Risk factors. Ages 15 to 35 is most common. Caucasian race. History of cryptorchidism or undescended testicle at birth. Remember the risk factor of cryptorchidism or undescended testicle at birth. Um, it is, like I say, the most common cancer in Caucasian males. It can often metastasize before it is diagnosed. There are two different types. There's the seminoma, which is not as aggressive as the non-seminoma, which if it develops at an earlier age and spreads quickly. And then there's also two types of there's surgery they can do. They can do, an inguinal orchidectomy or retroperitoneal lymph node dissection. So there's two different approaches that they can use for surgery on that. Cancer of the testes, you know, we already talked about the the seminoma and the non-seminoma. But cancer of the testes, they may feel a dull ache in their abdomen and groin. They may have pain in a testicle or the scrotum, enlargement or tenderness of the breast. Advanced symptoms may be a backache, pain in their abdominal area, weakness, and weight loss. Monthly testicular self exams from early adolescence onward is recommended, and usually, if it's found early, surgery may be the only treatment that is necessary. And if treatment begins after the onset of significant problems, chemoradiation may cause sterility. But also with this monthly testicular self-exam from early adolescence onward, it is on page 1658. It's best performed after a bath or shower, and you want to avoid touching the scrotum with cold hands because that may stimulate the cremasteric reflex. And then, of course, we have cancer of the penis. Cancer of the penis is relatively rare, especially in circumcised men. It usually does begin on or under the foreskin. If it's detected early, it usually can be cured. It tends to occur more in uncircumcised men who practice poor hygiene. So the vast majority of penile cancer is epidermoid or squamous cell carcinoma. HPV does increase the risk of penile carcinoma. The signs and symptoms can be a growth or a lesion on the glands, foreskin, or shaft of the penis. The color may change. The penile skin may become thick. And there's unexplained pain of the penis, and then swollen lymph nodes in the groin and irregular swelling at the end of the penis. Treatment is to remove the tumor and marginal tissues. Circumcision may be done on the foreskin, but early treatment is essential. And so for nurses, we have to address our clients' concern for sexual activity and the ability to have children. Now, this is Chapter 90, the male reproductive disorders. Next week, I will go through the female reproductive disorders. And then you would have a quiz. The first quiz would be over Chapter 90 and 91, which will be in week 3. So, if you have any questions, contact me via email. My email address is bolson@iot.edu. You guys have a great week, and I'm sure I will see you around.